ahead and get started. I was telling Steve that I think some people have been delayed that were going to be here from Blacksburg, so I'm going to apologize first for my introduction of Steve being brief. But I've known Steve for many, many years, and Tanasis is coming in if he would like to take over the introductions.
No, you're doing great.
Okay.
Those first 5 words were terrific.
Okay.
But here you walking here, I'm so glad I'm late because Stefan is doing.
Okay. Well, I've had the pleasure of knowing Steve for many years and watched much of his work along a number of different lines. I first got to know him through the Excite trial, which I think was revolutionary in helping us understand much about intensive therapies, particularly constraint-induced movement therapy. You all know that I've been heavily involved in that, or most people who know me know that I've been heavily involved with that. And I worked with adults and children, which is what many people don't know. And I considered Steve one of my mentors in the adult world. And then he has been gracious enough to continue on and mentor me as I developed my own work in pediatrics. But Steve's work was revolutionary in that because it really changed how we thought about stroke, how we thought about the stroke recovery process, and how we thought about approaching rehabilitation. I think one of the biggest gifts that he has given to the rehabilitation community is to really think about the fact that patients have the ability to recover in ways that we didn't think about 20 or 30 or 40 years ago. We kind of assumed that patients did not, after they had a brain lesion, have a lot of ability to recover. And his research has been groundbreaking in changing that thought processes. Now, he's been involved in a lot beyond just Excite and has been heavily involved with NIH and in formatting and helping structure the research efforts and research calls. I was just speaking with him about one that just came out that I'm interested in applying for. And so he has really guided the entire rehabilitation community and moving it forward. And I think we're all indebted for that. And I'm thrilled to hear him speak. I've heard him speak many times, but I always learn a lot. So I hope you all welcome Steve to the platform.
Thanks, Stephanie. Thank you very much. It's nice to be back here, and appreciate the kind words. I thought I'm going to try something very different for me, and people usually get up and give you talk about their work and what they're going to do next. But I'm going to try to put something in the contextual framework that's a bit different, and welcome your impressions. It's going to be a bit controversial and maybe a bit futuristic, but I think the time has come for us to step back and reassess who we are collectively and what we do, especially with the emerging concepts of personalized or prescriptive or precision medicine. And what I've been doing for many years relates to the idea of helping folks who've had strokes and doing this in a variety of contexts. So I know something about stroke rehabilitation, both as a clinician and as a researcher. So what I'm going to say is and project to you is in the context of my experiences and the work that I've done primarily, the pitfalls and even some of the prognostications that may be coming true that could have relevance to where we see ourselves today and in the future. So I know there are PTs, OTs, at least one physician, some engineers. Whom have I left out from disciplines so I can think about how I'm saying things? Okay, so I've covered it, right? Great, okay. I've got a lot of material actually, so, but don't hesitate to ask questions now or later. Feel an obligation to state my disclaimers. So I am on several advisory boards, and I am a paid consultant for Inspire, which is a company that's developing deep brain stimulation in acute stroke. Myomo, which is making, these are folks who make essentially exoskeletons, and I'm on their advisory board and have stock options. If you want to look up Myomo and see that its value right now is at $1.30. I suspect I'm not going to make a lot of money. And I consult with the Nasus Rukakis of Virginia Tech on a machine learning project, which we hope will evolve into very exciting opportunities for many people in rehabilitation. So what I want to try to accomplish in the time that I have, and it may run a little bit beyond noon, I hope you don't mind, is to visit this concept of personalized and precision care as it relates to stroke survivors, because it's becoming, these are becoming catchwords that have operational definitions, and I think one simply cannot accept those definitions because I think there's profound misrepresentation of what they mean in the public and how many companies promote themselves, failing to take into consideration the myriad of factors that we have to contend with in rehabilitation of individuals with stroke, whether it's the construct of devices or the array of treatment elements and behaviors we have to confront as we're dealing with a total person. So, as I said to you earlier, I can only speak with reference to what I know, and I know something about what I've done in the last several years, and so I will limit my perceptions based upon those experiences. As I've already indicated to you, make the case that there are elements of understanding and relevance that I think industry and to some extent our collaborators and colleagues in other disciplines don't take into consideration when we define what we mean by success or improvement amongst folks who've had strokes. It's a very complex and difficult conceptualization. And perhaps most importantly, to convince you, if you aren't already convinced, that when we try to define success in the rehabilitative process of individuals who've had strokes, at least, and this may be, I hope, relevant to a variety of conditions, both within formal physical rehabilitation and other disciplines, is that this can't be achieved without an interdisciplinary professional conceptualization and collaboration. It simply can't happen because there are too many aspects to human behavior for any one discipline to comprehend. And I think sometimes we fail to appreciate that. And I'm going to give you some examples as we move forward. So to lend some perspective, as I say, everything I'm going to show you, talk to you about, is based upon the stroke rehab model, based upon my experience predominantly. And to suggest to you that our outcomes and how we see the person, whether we are personalizing or talking about precision of care, is not based on any single surgery, pharmacology, or physical intervention. It is a comprehensive conglomerate. And I will get somewhat sarcastic as I go through this. I guess all of you watch TV and look at the nice pharma ads and all the beautiful people, right? And the product, the message is continuous and nonstop. Take my product, and you're gonna look as healthy and wonderful as these people. You have no responsibility beyond that. And it's such an absurd notion, yet we all buy into it. And I can tell you that I've had experiences in the last 5 years, both in a clinical environment and a research environment, in which patients who've had strokes, and we do a lot of work in the upper extremity, have come and say, well, now where do you put your hands to fix this? As though we have our hands are our pill, because there's an expectation that the responsibility falls on us as rehabilitationists, not on them, because all the messages you see is, we are here to cure you, and you have no responsibility. You need to think about the next time you watch, I don't care if it's Lipitor or Viagra, the message is fairly consistent. And we will pose the question, does one size fit all, and revisit that near the end. I need to say to you that what's driving me, and has for the last decade now, stems from an opportunity that was given to me by the American Physical Therapy Association, who were charged by the membership to have an external review of the profession, which had the cute acronym PASS, Physical Therapy and Society Summit, back in 2009, in which individuals and groups representing 24 different disciplines and the private factor, critiqued what was at the time called Vision 2020 for the American Physical Therapy Association. Where is it going to be in that year? And from that, several observations, stunning observations actually, emerged, which drove us to look further. My engagement was I happened to be on the steering committee to help organize this meeting. And several of us agreed to do that with the proviso that the product that resulted from this, the recommendations that came from these 24, 26 different groups and agencies, we would have control over the dissemination. And that was agreed to. What emerged from that, amongst many suggestions, but really relevant to all of us, is that in the context of rehabilitation in my world, I'm a physical therapist, here are 4 content areas that were totally underserved and were perceived as essential to our success in helping our patients across all diagnostic entities in the future. And they included telerehabilitation, genomic rehab interfaces, regenerative rehabilitation, and biosensing technologies. And most recently, we, APTA, have actually a group that emerged from this called the first group, added imaging. All kinds of imaging, not just neuroimaging, but imaging of the thorax to look at precise measures of thoracic expansion and cardiovascular disease. And it goes on and on. It's quite remarkable. So amongst the past recommendations that came from these variety of groups is that physical therapists at least need to be far more consumer or patient-centric. We need to eliminate the silos that separate education, research, and practice. That there's an opportunity to advocate for a role in prevention, in health, in improving health and wellness, establishing societal determinants of health, and most importantly, for what we're doing right now, is to seek and nurture collaborations between provision of care and new technologies. So that's what drove us from these recommendations. And first, Frontiers in Rehab Science and Technology was born from that meeting and consisted, surprisingly, of individuals representing all those content areas who were both PTs and non-PTs, who agreed to generate materials that could then be posted and used by any educational source who wished. By the way, for those of you who are not PTs, if you go to the APTA website and request to become part of the first group, they will give you gratis membership. So you can access these content areas and the information which is posted by specialty areas, which is emerging from the contributions of PTs and non-PTs and from a variety of resources, including webcasts, podcasts, PowerPoint presentations that are done by folks, and with a very clear stipulation that was not the role of FIRST to tell anyone how to use that information. It was there for accessibility and individual utilization. So the goal was to advance technology in a useful and timely fashion, create information dissemination opportunities, update this continuously, which we have now for 7 years, and devise a plan that will allow educators and clinicians to use this independently, or better yet, even collectively or collaboratively, and to do so in a cost-effective manner. So let me give you some examples quickly from a technological point of view of things that are being developed and have been developed as a result of our initiation, at least in the world in which I live. So this is a picture I captured quite deliberately to make several points to you. This is a presentation by the guy sitting right there at the end. His name is Patricio Bello. He's an EE, electrical engineering at Georgia Tech. And he was developing a concept, but he didn't know how to apply it. And so you see whom you see sitting around the table is one gentleman who's a PhD exercise scientist, several physicians, one sitting back there, PTs and OTs. And this is a brainstorming session. And so what Patricio presented was something that not too many of us thought of, but he didn't know what to do with it. Is to use the camera on your iPhone to track gait. And so what he's developing is all it needs to do is be positioned in a stationary point, some markers put on the side closest to the camera on the part of the patient, and then to capture motion in a video capture mode, and then transmit that for analysis from the patient's phone, by the patient. And this software is being developed now. The degree of accuracy, the fidelity with which this can be done, the education and comprehension capabilities of the patients, those are things that need to be determined. The important take-home point here is the guy had an idea, but he didn't quite know how to put it together. And this is precisely what we should be doing now. And so to get on my bandwagon for 1 second, because this is going to come up later, I feel very strongly about this. I think the collective we, whether one be in an engineering school or a rehab school or even fundamental science that has an interest in movement capture in some capacity. I think the notion of learning in silos, in the absence of interdisciplinary coursework at some level, is an obscure notion, no longer is relevant. And by that I mean the ability to capture opportunities to dialogue across disciplines so that one can at least surface ideas, and with those ideas create better understanding and ability to learn one another's lexicons and communicate more effectively. And that was simply an example of how that could happen. But you got to do it and step outside the comfort zone and be willing to embrace change. A lot of people don't like to do that, but I personally am very concerned about the future productivity and recognition we as rehabilitationists will have in the absence of such collaborations earlier on, even before students graduate. Another example that's being developed by Jadif Desai at Georgia Tech with us, he said, well, we're interested in haptics, grasps among people who've had strokes. And as many of you know, the ability to open a hand or close it is often compromised, and it profoundly affects our ability to manipulate our environment. Being able to have enough of an aperture, enough of an opening to grasp around something, well, that's fine. Figure out a way to manipulate one's upper extremity to get to that point. But once some form of closure occurs, often it's very difficult for someone to let go, that is, to open the hand actively rather than passively, because of a variety of factors, not the least of which is a potential sensory overflow from the stimulation which blocks the ability to activate the antagonist muscles, right? So a lot of patients don't have that extension capability, a large number of them. So what Jadif said is, everyone talks about haptics. What about the anti-haptics? What if we develop a glove? Tell us how we can use that glove in such a way that if it was loaded, it could open a hand. So through discussions, what we came up with, and now is being developed and explored, is what if for the person who can't open their hand, there is a receiver embedded in this very thin glove that is voice activated. So a very specific voice command that can be interpreted then engages a system that opens the hand or releases, increases the aperture passively. It's not like a Sabo glove, which has a lot of springs or rubber band equivalents that simply use the amount of tone that someone has to relax or let go. This is being done passively through a voice activation. Very clever idea. The point I'm trying to convey is you have to be willing to sit down and look at what someone's doing and then work together collaboratively to create something that can be very new and exciting. So this leads to a series of queries, many of which I've already mentioned to you. I don't think we are all prepared as well as we could be and probably could be facilitated if we embraced more interdisciplinary collaborations and communications during the learning phases. I think that would require a different kind of exposure in clinical and classroom environments. Requires all of us to think outside the box, which is, I think is kind of fun if people are willing to do so constructively. So if you, by the way, if any of this is thus far resonating with you, you might think about philosophy we have. It's worked so far. And consider this. We like to have conversations that are interdisciplinary, get people from different disciplines. You don't want to hear the same people talking about the same thing the same way. It becomes stifling at times, sometimes even competitive or antagonistic. That's not good. So we try to come up with interdisciplinary groups who have different perspectives on the topic. And when we meet to talk about an idea or formulating, whether it's a grant, a clinical application, it doesn't matter. We have one rule. It's a simple one, but a difficult one to comply with, and that is no one can use negative words. That's the only rule, and which makes you think before you speak. And the overall prevailing philosophy becomes, I don't want to hear what we can't do, but let's talk about what we can do. How do we make it work? And I think if people are willing to buy in to that conceptualization, it's remarkable how productive one can be. And this has happened for us several times, and maybe for some of you as well. Someone who's may not even be in your discipline says, yeah, but what if you, and someone else says, you know, I never looked at it that way. That's the beginning of creativity in an idea. And that's the fun part. If people are willing to put down their guard, realize this is not a question of any one person's ignorance. It's an opportunity for us to learn and develop from one another, which I think is the optimal way that one should engage in communications. So just, if you got nothing out of this time here, just take that thought with you. Okay. So this is one way we can make ourselves mutually responsible, is by embracing a concept of positivity in what we do. And it is hopeful that you believe that this can have an impact on the totality of who we are as professionals and how we can favorably move healthcare and society forward. So let's visit for a brief moment, and I'll come back to this at the end, these operational definitions of personalized and precision care. So personalized, this is a bastardization of many definitions, but it's the fundamental idea. We're really looking at someone's individual requirements. What do they need? How do we customize something that is unique to that person? As opposed to precision. Precision goes a little bit further, and recognizing that it's an emerging approach. And we look at variability, but we dig deeper. We go beyond the obvious. We look at genetic profiles, lifestyles, histories of movement and behavior. And from that emerges the possible notion that maybe if all of these factors help to define the ultimate or the penultimate way we should handle a person, then maybe one size doesn't fit all. Maybe there are gems here which we're still discovering, and I'll get to those in just a moment, that help us to redefine how we specify each individual and what our expectations should be. It seems surprising to me that Walter Frontero is an outstanding rehab medicine doctor, led a review group for the NIH in 2016 that were charged with reviewing all of the present and emerging aspects of care and rehabilitation and defining what should be done in the future. A very noble effort and an outstanding group of people. And these 9, and I've gone through this document, and these 9 that appear here, not in the order in which they were presented in the paper, define, I'm not going to go through these, you can hopefully read these, are areas I think you would agree are important to the rehabilitative process and need to be explored in the future. It was a surprise to me that at no point in these 9 core areas did anyone even address the concept of personalization or precision for future considerations, which I thought strange in 2016, 17, when this was becoming a hot topic. But there were 4 that did. And so I single out these 4 because they talk exactly about the importance of looking at individual differences as a basis for making decisions. And I think one of the 2 that stick out for me and are relevant, hopefully, to everyone sitting in this room right now are mechanisms and markers of activity and function and technology and rehabilitation. The whole 9 yards, any form of technology, from skin to some kind of implant, and the extent to which those need to be tweaked, personalized, so that they take into account a variety of descriptors that define the uniqueness of a person. Because I don't think we do that very well. And so if you want to look at that reference at some point, I just thought that remarkable, that there was should I say, an oversight or a lack of recognition of how the nature of personalization did not even enter into the future discussions in those first 9 topic areas. Okay. Now, let me start to drill down to what's...
Can I ask you something on the previous slide?
No.
All right.
Sure you can.
So why the need to say bending the arch of technology towards rehabilitation and health? Where is the arch going if it's not going there?
I can't answer that question for you. I did not make up the title of the working group. I don't know. I'd have to go and look at the specific words that were stated. When I skimmed through this, I was looking for any indication of references to the need for precise measures or care, or the way in which the topic area addressed personalization of the target, which is the patient. I'll be happy to, I've got the article with me, I'll be happy to share it with you. We can,
I just want to quick follow-up on that. In the Penn State workshop that we were both together 6 months ago, and you're part of the final panel, there was a very relevant discussion in terms of how much technology is being used for basic science without a bridge to the bedside.
we're all let me be very constructive about this. We're all on a learning curve, and I was talking to a couple of you guys a little earlier, that we're experiencing this now, and we work more closely with engineers than maybe many other institutions do. We're trying to get past this notion of let's build something, and maybe it'll have an application, or we think it has an application, but let's do the best we can, and let's just talk to some people who do applications in improving the human condition. And it was stunning to me that the magnitude of the disconnect. All the more reason I'm trying to say, as I indicated earlier, that there's a need to work collaboratively from the get-go, not after the fact. It's a waste of time and resources. But convincing folks that that's the way things should be done is a paradigm shift for many folks who are, for whatever reason, reluctant to embrace change. So I think what we're trying to say at that meeting, and many of us have been advocating for quite some time, is that the interface of technologies and rehabilitation requires a collaboration from the get-go. It's not, let's build something, because we're engineers and we like to make stuff, whatever, whether they be electrical, mechanical, whatever, it doesn't matter, quite frankly. It's the conceptualization of working together to foster a better product in a more timely and cost-effective manner. I can't believe anyone could argue that point, yet getting from the point of realization to the point of implementation is a major hurdle, which is slow, from my point of view, too slow in coming. Okay, so let me drill down to some very important personalized considerations. My mentor was a gentleman named John Basmajian, who knew a lot about EMG, and I was really interested in learning more as a graduate student in how this information can be used optimally. And he helped develop this concept of EMG biofeedback in stroke, and I inherited that from him quite unexpectedly. That's not what I was doing when he decided to go back to Canada. And what this is one of many slides representing a critical question. For those of us who know something about movement control, you know, when someone has a stroke or other brain pathologies which effectively balance between antagonist muscle groups, what we try to do is to achieve this balance back towards normalcy. And what we did with EMG feedback training for both the upper and the lower extremity in folks who had had strokes was to make the assumption that in order for people to function and move better, we have to be able to reduce the hyperactivity in some muscles. In the case of the upper extremity, it's muscles which seem to bend things, and the lower extremity, the muscles are over-exaggerated, seem to straighten things out. I'm trying to make this real simple. And so what we found is with this training, we naively believed that we could inhibit hyperactive muscles, recruit the weakened antagonists, and show very nicely this very clear demonstration of reciprocal inhibition, which is conceptually what this thing is called. And what we're able to demonstrate over prolonged numbers of sessions is that indeed we could do that. But what struck us as being remarkably unusual is that you don't turn off one muscle and recruit the other muscles. You change the ratio of activity between the two of them and hope you can generate meaningful movement out of that. So what we did, and that was really an revelation, and I apologize because I can't find my original data, but this is data that is in principle exactly identical to what I have just said to you. This is Silva and his group in 2014. And what they were doing in people who had had strokes is doing a reaching task and dividing it into two sections, the initiation of the reach and the termination of the reach. And they were looking at antagonist muscle pairs from two planes of movement, a sagittal plane and a plane that aligns with the scapula. And so I want to draw your attention, this is the latter part of the movement, and point out to you something that those of you who are clinicians would already know. If you look at the ratio of activity for any one muscle pair, you'll see that the magnitude of that ratio is always higher. Contralesional limb means the affected upper extremity, as opposed to the healthy non-dominant limb, kind of comparing the two. And when you do these movements, the magnitude of the higher this number, compare the numbers, it's always higher, the greater the amount of coactivation. So we saw that, and what I did is I submitted a paper to a very prestigious journal in 1985 with a somewhat bold suggestion that what we want to see when we do an intervention such as biofeedback is not necessarily as much a change or improvement in the ratio, but to examine the variability across all the patients. Because embedded in the variability is the noise. It's the difference in how each person responds. And maybe there's something about that that will inform us as to how we do things differently. So that was 1985. And so it was a data set in which I tried to generate a philosophical piece about having us entertain the variability in responses across individuals rather than the absolute change in number. And there's a lot to be hidden. It's not just noise. It might be an indicator of the amount of spasticity or other factors that are contributing to the differences in ratios. You following me so far? I thought it was a good idea. And what I got from that was a rejected paper with the notion that makes no sense at all. We're not interested in that. What you really want to do is, did you change this ratio or didn't you? And just kind of let it go. But I really think, as I think back on that now, maybe that was kind of a precursor to this concept of personalization. You really want to look at the individual differences more than the overall group change, because there's a lot of treasure, a lot of gold lying in those individuality conceptualizations. And I think that's precisely where we're headed now, is to look at what makes one person different from another, but now we have some more additional molecular and biological tools that will help us do that. And so that's where I think a lot of the excitement lies. Okay, so what emerged from all that biofeedback work were some predictors as to a relationship between reacquisition of function, being able to use this upper extremity in the real world, and physiological measures. And the biggest predictors for improvement were not necessarily the magnitude of the change in these ratios, which is why I was trying to argue for looking at the individuality of the noise, but changes in range of motion, which perhaps is a surrogate for the change in the ratio of coactivation. And in fact, the ability to start to extend the elbow and raise the wrist, most importantly, initiate movement in the digits, seem to be the highest correlation with a change in functional measures, one of which we called the Emery motor test. It was basically a time test for a series of tasks, which was a modification for something that's called the Jepson-Taylor hand test. A dear colleague of mine, Edward Taub at the University of Alabama, who I knew from biofeedback, he was doing biofeedback of skin temperature in Raynaud's disease and had done a lot of animal work looking at constraining a limb, casting it after deafferentation in monkey models. I suggested that why don't I use those criteria and do what we call forced use, making a patient use the impaired limb by immobilizing the better limb. And we published a case study back in 1981 demonstrating that these changes were quite prominent, and then a more detailed study on what we were still calling forced use because we didn't have the behavioral piece to accompany the real forced use. The addition of the behavior, which Dr. Taub developed very nicely, and shaping procedures to fundamentally reward individuals for improving aspects of their movement was rebranded as constraint-induced movement therapy. And as Stephanie said earlier on, we had the good fortune of putting together a major clinical trial, which was successful in demonstrating that folks who had these movement criteria that I just explained to you could, in fact, with a fairly intense exposure to constraint therapy for a couple of weeks, improve their function. I'll explain that to you in just a moment. And let me just, and I think what, let me just go to the data first. So this is a summary of those data. And to give you an idea of how the 7 sites that participated in the study nationally structured this, is we had patients who had these inclusion criteria, and they were and they were all 3 to 9 months post-stroke, so they were kind of subacute, were either randomized to receive constraint therapy for 2 weeks immediately or delayed for 1 year, during which time they could do whatever they want. We have no way of monitoring that, but not constraint therapy. So we knew after 1 year, those people who were delayed then received the constraint therapy 1 year later, and the people who received it right away, we followed essentially for a second year. Okay? The evaluators didn't know which group the patients they were seeing were in. All they knew is they were seeing patients at set points in time to do evaluations. And one of those evaluations was a modification of the Emery motor test that Dr. Taub now included a qualitative aspect of movement called the functional ability scale, and renamed that, quite honestly, unbeknownst to me, as the Wolf Motor Function Test. And that was an outcome measure for this study. So what you see here are real-time measures on the left of the motor function test, and the group with the circles was the earlier or the immediate CI therapy group, and the one with the boxes was the delayed group. So you can see that the rate of improvement over a 2-week intervention was more acute when people received this relatively earlier to their stroke than it was when they received it later. But all patients can improve no matter what point in time they were seen. And another measure that Dr. Taub helped develop, the motor activity log, this is the amount of use. These are measures of asking a patient in a series of questions, how often did you use your limb, your affected limb, to do the following tasks? And those on the scale, and those two, so higher is better here. By the way, lower is better means faster times. Higher means more ability to move this. So you can see the same thing is true there. And what's really important, which we've seen in a lot of clinical trials, at least in rehab, is if you look at the endpoint, whether it be at 12 weeks or fundamentally 12 months or 24 months in the delay group, you kind of get close to the same points. There was a study called the Vector study, very early constraint therapy that Alex Dromick ran in folks who were 5 to 7 days post-stroke, and examined their ability to reuse their limb nodes. Great, it happened. And then did a following study that demonstrated it didn't matter if you had 2 hours or 3 hours of constraint therapy in acute stroke versus a control usual care. There was no difference between the three. So therefore, constraint therapy was not effective at 90 days, a time point after the completion of the constraint therapy and at 90 days. There is one more paper coming, and that's 1 year. And at 1 year, they all get to the same point. So the point being that sometimes you see these delayed responses, and you don't know what the influence of the early interventions have on later behavior. We tend to get to some of the same points, but it takes time, even in these patients. It's just something worth remembering. We actually recorded the number of minutes. There's a lot of work now on dosing and a lot of concern about not getting sufficient dosing. And we actually recorded time. Now, if you looked at this, this is the change in the log function of the Wolf Motor Function Test. For those in the immediate group and the delayed group, you see those dots. They're all over the place. So the x-axis is the amount of actual time that each one of those people spent over 2 weeks in constraint therapy, doing constraint therapy, not just sitting there, the time they actually spent doing this. And there's not much of a change if you just look at the big picture. And like everything else, and this is where the individualization comes in, you gotta break it down into its component parts. So if you just looked at these data, one would probably say, well, there's not very much going on here, until you begin to dissect the information, and then much is revealed. So to fill you in here, there are 2 forms of therapy that made up the totality of the constraint-induced the EXCITE trial. One's called ATP, and the other is RTP, adaptive task practice and repetitive task practice. Adaptive task practice is fundamentally shaping. It's doing incremental steps of increasing difficulty, and through praise and documentation, rewarding patients for their progressive improvements. Repetitive task practice is just that. You take the totality of the task, and you go through all the motions and repeat the task. So the way this was structured is that those individuals who we defined as higher function amongst all of the stroke participants in EXCITE had a bit more movement in wrist extension and finger extension. And those who were lower functioning had less movement, able to initiate movement about 10 degrees of the wrist and just begin to move the thumb in two digits. The potential was there, but it was not as profound. When you then began to break this down by time spent in adaptive task practice and repetitive task practice, where this is the totality of the time and this is the distribution of the participation. What you need to know is that the dotted lines represent the lower functioning patients. The solid line, the higher functioning patients. And 2 things emerge. Once again, lower is better, faster times. If you look at the relationship of the improvement on the motor function test to the dosing, everyone with me so far? If you look at the adaptive task practice, the lower functioning patients do better when they are exposed to adaptive task practice than repetitive task practice. The higher functioning patients do better with less treatment if they have more repetitive task practice. So the specificity of the nature of the training may be related to the degree of impairment and the dosing. You don't need to have an awful lot. You just need to have the machinery and the right form of treatment in order to maximize the improvement. Are you all following what I'm saying here? Okay. But we don't talk about that sometimes. We just dump all the data in a big pool and look at the change. Yeah.
Is this kind of implying that there is a ceiling effect for how good you can get longer term?
I think there's a potential ceiling effect based upon the nature of what you're trying to do with someone and where they're starting from. But that's probably true for everything. But this requires a level of analysis and thinking that we sometimes neglect. And there are multiple factors that contribute to this as well. So let me move on because I'm running way behind. Moreover, there are errors here. So it turns out we had a subset of higher functioning patients who wound up getting more adaptive task practice than they were supposed to. And that's represented by these funny looking signs here. And while repetitive task practice was more potent for the higher functioning patients, if you overload them with not the ratio we wanted, a disproportionate amount by accident, not by design, which is often the case, they actually could do better with adaptive task practice with a less amount of that adaptive task practice. You put these pieces together, what it says for higher functioning patients, you do the repetitive task practice, but you throw in smaller ratios of that adaptive task practice as well to optimize the improvement. And this is all from dissecting these data and looking at them very carefully. And the lessons learned. Now what we can do that we couldn't do back then with a degree of clarity and, that we wished is to look at a host of additional imaging data, to look at the performances of these individuals and their behaviors here, and how it relates to the specificity of lesion or other measures we choose to extract from a scan. Okay, but this is work that could now be done that wasn't done back then. However, we did have the ability to do some measurement. And to do that, we had to apply for a second grant to do imaging and TMS on another subset of patients. Not the patients we wanted to do on the EXCITE trial. By the time this got funded, we were halfway through the EXCITE trial. So we had to recruit a whole other bunch of patients in order to do the constraint therapy, in order to do these studies. And just to orient you here, this is looking at that activity. It's evoked from wrist extensor muscles. And this is the affected side. It's on the left. The right is the unaffected side. These are maps, two-dimensional maps, of the magnitude of responsivity to cortical stimulation at threshold. And the color coding is the amplitude of the evoked MEP at the exact location where it was provided. So not terribly surprising. The amount of activity at baseline might be a little smaller in the affected side, and after 2 weeks of constraint, that enlarges. And we follow them for 4 months without constraint, and it got even larger. That suggests to us that among patients, the use of the impaired upper extremity continued on after the restraint and the constraint therapy were removed. Okay. So we did something else, that's not good enough. We also asked ourselves, and Lumi Sawaki took the lead here, if we divide these patients up into subacute and chronic based upon time post-stroke and basically do the same thing, do we see differential responses? And once again, this is a mapping, just as you saw before. The little round circles, I see one's been misplaced, unfortunately, were the center of gravity where the major activity could be seen. So if you look at the affected side, once again, you can see, this time it's on the right, you can see an increase in the size representation of the affected side under the subacute and the chronic conditions. Right. You use the impaired limb more, you get more cortical activation. However, the geography, the topography of the responses changes. For those who are in the subacute area, it looks like the location moves slightly anterior towards the premotor cortex. For those who are in the chronic phase, it looks like it moves slightly posterior. So maybe there's a differential responsivity to the cortical representation of movement that's related to the relative chronicity of the patients. So we're starting to learn more and more, get more and more extractions from these kinds of observations, and that was the purpose of showing that. Once again, speaking to the concept that there are factors that contribute to the uniqueness of each patient's response to this particular intervention. So now to add one thing that was totally missing. This is a model that, may I just show? No, it won't. This is a nice model that was developed in 2005 by Sunderland and Turk. Here's the impaired limb, and if you don't use it, it just sits there, the area gets constriction of this constriction of the cortical representation contributes to the impaired motor control. If you fail to practice, it'll get even more constricted. And then you have poor functional ability. And if you teach compensatory behaviors of the other upper extremity, then you're going to have even less use. And that leads to no spontaneous use whatsoever. That's the model. We don't think that's exactly accurate. So let me build upon that. We believe that the notion of constriction actually occurs after the lesion and is a consequence of not using it. That's when these things get more constricted. And in order to overcome that, what one needs to do is to actually engage very specific aspects of the brain that are known, whose outputs are known to influence the motor cortex. And when it adds to that the relevance and importance of reinforcing the behaviors, meaning that people can do more repetitions, feel less sense of exertion, and most importantly, can induce problem solving within the context of the training. That's when you start to see cortical expansions and overcoming what some people refer to as the learned non-use. That's nice, okay, kind of makes sense, but there's still things that are missing. And here's where the individualization comes in. What none of us considered in developing these models are several factors. The extent to which attention, awareness, and concentration can influence responsivity. Sometimes we don't even monitor those things. We say something in passing that the patient doesn't attend. We may actually have measures of that, but we don't always make use of it. And then, secondly, what we fail to do are consider psychosocial and cultural factors and how they influence an individual's behavior and responsivity to what we're trying to do. Yet, when you look at models of treatment across the spectrum, I'm not convinced that these considerations are even there. And there are probably neural correlates to all of them. So in the spirit, once again, of looking at the individual and providing what some people want to consider to be precision medicine, I find it hard to believe that we can extract or eliminate these considerations as part of the totality of the equation that goes into the definition of precision. So this has evolved into even bigger and better things. I want you to watch these two videos very carefully. My colleague Carol E. Winstein at the University of Southern California basically took the Excite trial and took it to the next level, something that we called, she developed a procedure that she called ASAP, and for Accelerated Skill Acquisition Program. And it includes behavioral considerations as well as physicality of having folks do it with or without elements of constraint therapy. But I really want you to attend to is the following. This is a task practice. I want you to look at the person's motor skills, but their affect as well, okay? The behavior of the individual. And what you're seeing here is a difference in time of about a month. Let's see if I can get this going here. Oop, sorry about that.
Could you lift that little?
This guy's a cook, by the way, so we're trying to come up with a
Yeah,
task
that
which
might
is
not
relevant
be
here.
Hold on for a minute, because you would need both hands for that. Let me, this was actually the lid. I'm going to visualize it for you, because this is actually the lid we had. Go ahead. Can you lift that up?
So he has an extension. You can see that, right? It's got some of the goods are there.
Good, good. Okay.
So this is all part of the ICARE, Interdisciplinary Comprehensive Arm Rehabilitation Evaluation. This is after a month, same person. So I want you to see the differences here in skill and behavior.
Well, good morning, everybody. As you can see that this is the cooking channel. What I'm going to do is take the saucepan lid, I'm going to remove it, set it right inside the saucer here, and I'm actually, if you want to see, these are marbles in water. I'm going to actually take the marbles, leave them in the pan, and just simply pour the water off. Almost like you're doing with spaghetti. You're draining off the liquid of spaghetti before you put in the yummy stuff. And the key thing is that I cannot push any marbles inside the second pan. Okay. If you notice, I had my hand and it twist in, which I was having difficulties the first time. Now, the second step to this is taking the other saucepan and placing the water back into the first pan with the marbles. Man, that's yummy. I'm getting hungry just watching all this water go back in.
Yeah, me too.
And then my last step is to take the sauce lid out of the frying pan and put it back onto the saucepan.
Ah, that's great.
Can you see
Thank you.
Can you see the difference in behavior and skill? So that it's there, the machinery is there. So we're impacting more than one thing, but often we don't measure them. We don't even document them. So this is, I think, a fairly vivid example of how we need, if we're going to try to convince someone that we're trying to improve their function, how we can go about doing that more effectively through more precise measures. I was given an opportunity in 2002 to give a major lecture to the physical therapy profession. And I call it Look Forward, Walk Tall, exploring our what-if questions. And amongst the things I said then is, what if we were to demonstrate that physical therapy is more than physical? To what extent would that demonstration influence what we teach our students and how we provide or reassess our practice patterns? I think I'd be saying that today as well, and perhaps even more germane. Made reference to the fact that there are biomarkers that exist for assaying epithelial cell growth factor, cerebral spinal fluid, blood assays for light glycine, looking at other neurotransmitters. Don't we need to know more about that in order to have a better handle on how we're improving our patients and then documenting the value of that proof? And moreover, can you imagine the vast potential for devising new interventions, modifying existing ones, or improving the outcomes of our patients through the introduction of measures of titrated molecules or neurotransmitter precursors, et cetera, et cetera? But I think that's exactly where we are now. And so makes me feel good to look back 17 years ago and realize that perhaps some of these things are becoming a reality, and the extent to which we're preparing future clinicians and researchers to appreciate those is important. So the impact that such advances will have on promoting the science and art of physical therapy awaits the minds and gentle hands of our future physical therapists. And I think it's absolutely true today across disciplines. We've gone on, we being an international group, to develop an app for the upper extremity. This app, I just checked this the other day, now has 3,600 downloads globally and almost 10,000 visits. So if you're interested, by the way, this is a free download. Just go to www.biotherapy.org and on either Android or iPhones, and you can download it and play with it. So all a decision tree based upon evidence that takes only almost exclusively, well, it does take multiple factors into consideration. If you haven't seen it, we have these various filters that take into consideration information upon aphasia, attention, language difficulties, and how the choice points change as a function of those considerations in coming up with interventions that are designed to fulfill what happens. By the way, what this is based upon is kind of where we started. Can the person lift their arms up or not? Can they raise their fingers? Can they open their hand? And they're all yes/no decisions. And this is a timeline that has 12 weeks as a critical function point. I think the data are pretty overwhelming, that if you can't begin to open your hand at 12 weeks, it's highly improbable that's going to happen. But what's filled in these boxes is the evidence for what you do at those moments in time. And this has been, for those of you who may have downloaded this at some time, we now have videos for every intervention. And we are now in the process of updating the evidence since 2015. However, what's missing from that is the role of polymorphisms, factors, nucleotides that exist on genes that have been demonstrated to influence the recovery or responsivity or even the diagnostic entities emerging from a stroke. And there are 27 of them. And the ones I've highlighted in red, ApoE, BDNF, which you probably can recognize, and several others, are known to influence the responsivity to rehabilitation specifically. But the point to be gleaned from this is that there are multiple molecular genetic factors that we are all ingrained with that can, to varying degrees, impact our individual responsivity to an intervention. And slowly but surely, our knowledge of these is emerging. Most of the work has been done in brain-derived nerve growth factor and ApoE, as potential of the presence of polymorphisms are thought to influence the responsivity to therapies. And knowing more of that is going to be invaluable to our future. I was going to say, let me just say a few words for the work that Dr. Rakakis and his group has done starting at Arizona State and Carnegie Mellon and now here. All boils down to the notion of something that, in the interest of time, I can't get into a lot of this stuff, but let me summarize what I think is really exciting in 1 minute. So I've known you for about a decade now, and what attracted me to the work that the NASAS was doing at Arizona State really is that they were at first wanting to provide some form of feedback, and they were very interested in audio and music feedback to movement. And I thought that was really cool. But they do much more than that, and fundamentally looking at ways in which one could initially use a very large camera array system to look at what, by my count, amounted to 44 different kinematic variables. And those kinematic variables look at every aspect of the upper extremity. And compared, let's go to one point, because I don't even know if the NASA is aware of this. To me, all of the work that you've done, what impressed me more than anything else is to come up with a quantification of qualitative aspects of movement. And this overview is was always very intriguing to me. This is an aerial or superior view of a person sitting as they would engage in a reach towards a target. And what they did was to have several able-bodied people do this and to define the nature of that trajectory and its variability across able-bodied individuals. Because if we're going to look at any one of those 44 kinematic variables, it makes sense to ask the question, well, how different is it really from what an able-bodied person a bunch of able-bodied people would do given their own innate variability? So this shaded area represents the variability in the whole, getting from point A to point B. And anything outside of that is an aberration. So it stands to reason that in a specific task, if you look at this over this time domain in which someone is going from one spot to another, at any one point, how different are they in the variable that you're looking at from what one would expect to see within the variance of able-bodied people? And can you quantify that in a way that is meaningful? Okay. So fundamentally what they did is they defined the performance for any of those variables. They made this into a binary. They defined the performance of any one of these variables within this range as 0. Perfect. We can't tell the difference between you and the range of able-bodied people who were doing the same task. Anything that starts to fall outside of that range moves up to away from the 0 binary towards a 1, where 1 is defined as far away as you can get from this particular hull. And so the question that one would have, until I explain it to you, or he would, is, well, who cares? Why would you want to know this? But what we cannot do, is quantitatively define qualitative aspects of movement. We don't see the same things. We see what we want to see, but that's not, I don't mean that to be a derogatory comment. It's in the context of what we've trained our eyes to look for when someone moves. So this is what was really intriguing that came out of this work, and then some very clever ways in which one can quantify and document that. And that has resulted in several publications and papers. But it's labor intensive, but what it does represent is the first step towards a machine-based learning interface. And so what's happening here now, and several of you I understand will be will be participating in this, is can we come up with a nomenclature and a definition of movement components within functional related tasks that anyone can identify as being important to movement, that can be given a scaling or a value based upon the initiation of the movement and its execution. Can individuals who see these movements score them the same way? And if you do this enough times under different tasks, can you actually create templates which are the basis for machine-based learning? And at some point in time, can this be transferred to a camera evaluation of movement and quantification of what goes on within that movement, both in the home, the laboratory or clinic environment, and ultimately in the home environment to be transmitted back to the clinic, to provide some indication of the qualitative aspects of movement in a quantitative manner. Now, how badly did I bastardize that? Reasonably close?
Very good.
Okay, whew. If he says very good, then probably I'm reasonably close. In the interest of time, I wanted to talk to you about a few more examples of variability. Something else we got into only because I was interested in biofeedback. That's how I started. And about the time posturography machines came along, we thought we could use glorified center pressure feedback. And you show someone a cursor on the screen, which is related to your postural control. Can you train individuals who are fallers to improve their postural control? Big grant from the NIA called FIXIT studies, Frailty and Injuries Cooperative Studies and Intervention Techniques. Can you come up with a technique or techniques that delay the onset of falls in older adults who are fallers? And we thought we'd apply along with a lot of other people in the country. And about the time I was obligated, part of the grant said you have to put together different teams of people who have different levels of expertise. This guy shows up, as I put a call out in my institution, who's a professor of biochemistry, also happened to be a Tai Chi grandmaster. And he wanted to study Tai Chi. This is before there was a Center on Complementary and Alternative Medicine at the NIH. And after a great deal of thought, and reading up on this a bit, I said, geez, high tech, low tech, west, east, new, time honored, comparable, they're diametrically opposed. Let's make this a 3-arm intervention in which one arm would be Tai Chi, the other computerized feedback training, and the third a wellness education control. What we weren't counting on is that the Tai Chi intervention would be the most potent in the country to delay the onset of falls, and is now provided, I think, routinely in a lot of at least independent living facilities. What that led to was a much more detailed study in truly frail fallers. And we had this proposal that we would look at the change over a 48-week interval of these different forms of training and controlling for the dosing. And we hypothesized we would delay the onset of falls over this time period, more so in the Tai Chi group. The Tai Chi trainers who knew nothing about research said, it's not going to work. I said, what do you mean it's not going to work? You've got people who can't hardly stand. You're not going to see them influencing their falls for at least 2 or 3 months. We ignored that, and that's precisely what happened. We had a failed study because of our hypothesis. However, if we looked at the falls across centers from month 4 to month 12, there was a significant improvement delay in the onset of falls in the Tai Chi group. And their explanation is they won't let go of anything before they have that level of confidence. So there's a lesson learned from that. When we explored all the falls, and here's where the individualization comes in, I think the things we learn is, well, we got to improve our endurance, improve your strength, improve your balance. Yeah, those are all important considerations. But you know what the most single important factor turns out to be amongst community and some nursing home elders who wish to walk independently? It wasn't any of those. It was divided attention. Because when we adjudicated the falls, we first thought the responses that we got, the explanations that we received, were excuses not to lose one's independence. It wasn't my fault. That rug was not supposed to be turned there. I saw it, but it wasn't my fault. The same explanation over and over, site by site. And after a while, we realized it's not. People aren't just saying the same thing because they don't want to be suspicious of not having their independence. I think they really meant what they're saying. They saw, but they didn't create the appropriate movement to avoid the obstacle. And what I regret at that point in time was we didn't ask the most important question. Do you remember what you were thinking about when the fall event occurred? Because the greatest example for all of you who may have elderly parents or grandparents, I'm sure you've experienced this. When you go walking with them, as you're walking and talking, they'll stop or they'll slow down because they cannot coordinate, integrate the concentration to the words with the movement. It's the most profound example of compromised divided attention. And so the extent to which one's attention is compromised becomes an important discriminator for what we do in falls prevention in older adults. So I just want to take this notion of individualization to another level. I'm going to move this forward so we can leave. Just trying to do too much work here at one time. This is all Vanessa's work. So for the future, I think the factors that influence what we can do are our ability to have our patients comply, caregiver engagement and involvement, and this needs to be part of the team, overcoming this pharma phenomenon, socioeconomic and cultural considerations, home preparedness, whether it's for creating a gym or therapy environment in your home, which is going to happen more frequently, it costs. I've already talked to you about the Tai Chi stuff. I won't do that now. By the way, we do a whole nother 3 years of biomechanics of Tai Chi. And those folks who are the Tai Chi participants who differ from usual care is we saw biomechanically where that is clearly manifest is in gait initiation. Their ability to do a weight shift from one leg to the other as they're initiating movement, the smoothness of which that is done, the coordination between center of mass and center of balance is so profound in Tai Chi practitioners than it is in participants who are not, is a critical factor in postural control as it relates to the training that happens in Tai Chi. Now, no patient or person can tell you that, but we can actually measure that biomechanically. It's kind of an important byproduct of that. I can't go through all of this stuff about evidence. And one or two more things, because I'm really excited about this. We're now doing another project with microtransponder, vagal nerve stimulation. These are implants to the vagus nerve. The outputs from the vagus nerve through the are multiple. Vagus means wonder. So the vagus nerve is the parasympathetic innervation for everything in the body from the head to the left colic flexure of the gut. It's innervated by the vagus nerve. But amongst its outputs are to the locus coeruleus, that's indicated in blue here. This is a noradrenergic pathway, and to the nucleus basalis by way of this tract here called tractus solitarius, and that the outputs are profuse to the brain. What's exciting here from preclinical work in rat models of stroke is if you are now motorically training a rat that's had a stroke and lesion one of these two locations, they can't relearn. So now the question is, if you stimulate them in the context of retraining, can you relearn? Because the outputs from these tracks, these nuclei, seem to invade motor areas that are not necessarily accessed through traditional training. And that's where some of the excitement lies. I've seen some videos of patients who've gone through this. It's pretty encouraging. That's why we're part of this trial. Therein lies the pathways as I just explained them to you. So the notion is a person has the implant, has a receiver in their chest, and the receiver is activated by a click, which sends a half millisecond pulse, which is timed to be engaged with the initiation of movement. This is kind of what it looks like very briefly. The therapist has the clicker in her hand. With each movement this patient's making, this is a task in which you have to reach and move a series of objects. With every movement, she initiates a click. It's unperceptible. It's submotor it's sub-perception threshold. The study is a double-blind study. We don't know if the patient's receiving a sham stimulation or the real thing. After 18 sessions, something has changed. By that, if the person was a control to begin with, they get another 18 sessions. But now with stim, if a person was a stim, they get another 18 sessions continuing with the stim, so we can look at the longer duration effect of the vagus nerve stimulation versus a transition from therapy with no real stim to therapy with the stim. I have seen some changes that I don't know, but amongst the patients we've had thus far, one patient who I was observing as she was doing a task that involved picking up beads on a plate with a spoon, was saying to me, I was asking her how she's doing, and she said, I don't have to mirror, she used these words, I don't have to mirror my movements with my other hand anymore. That's a level of perception that I don't think a typical patient would say to you, and I just hope she's in the STIM group, because that's remarkable. And I just kind of peek in periodically to the session to see how things are going, and the extent to which the STIM coupled with the OT is beneficial. I mean, we won't know yet. This is being done at 9 sites in the United States and 5 in the UK. It's not trivial, but there's a lot of auricular therapy done for vagus nerve with some degree of specificity, but the effects are far more profuse. They're done for pain, modulation, epilepsy, and a whole host of other phenomena. So I just wanted to let you know that it's kind of going back to some of the contemporary things and extracting what might be unique for patients. So the take-home points to ponder, well, I think a lot of the money that's being used thus far to influence us in what we do for our health have complexities that are not obvious, especially if one is interested in not considering the biobehavioral changes that are required to improve, and you can't simply compartmentalize people. There's a disconnect between what we exist right now and statements on the quality of life of individuals that needs to be improved, and pretending or assuming that there is none of these complexities, compounds, or obstructions to solutions. There's a need for interdisciplinary collaboration in all kinds of diagnoses, and solutions are embedded in better understanding of our genomic and molecular composition across disciplines, and indeed one size does not fit all. So this is the original definitions I gave you about personalized, individualized, personalized care and precision care, and I suggested that maybe it shouldn't be one or the other, and what we really are doing when you take into these considerations, I would suggest, is precisely personalizing what we're doing. And that's, I hope, where we find ourselves and our role in working with these patients as well. So one of my favorite expressions to my colleagues is onward and upward, I was really intrigued by what this actress of the 19th century was quoted to say. The sacred burden in this life ye bear, look on it, lift it solemnly, stand up and walk beneath it steadfastly. Fail not for sorrow, falter not for sin, but onward, upward, till the goal ye win. And I think that's true. I want to say that what I say is may we be inspired by what we see, hear, and read, even more so by those with whom we interact. May we transport that inspiration along our personal journeys to impassion those we meet and educate. It's kind of what we do. I've had a lot of funding over the years, and these are my funding sources. And my university's obligated me to do this. Don't want you to concentrate so much on the grants. There are quite a few of them. These are ones in which I'm paid in some capacity over these years, but more the collaborators. And I'm very proud to say that amongst all of these undergraduates and master's students, DPT predoctoral students, neuroscience students, the whole 9 yards here, that more than 200 referee publications have come from those. And every one person who makes up this group, whether they be an undergraduate or graduate students or postdocs or whoever, or colleagues, all have had their names on papers. So, because they've contributed, I'm very proud of that. So Mark Twain is my favorite author, and one of my favorite messages. 20 years from now, will you be more disappointed by the things that you didn't do than by the ones that you did? So throw off the bow lines, sail away from the safe harbor, catch the trade winds in your sails, explore, dream, discover. And last note of caution, two of the greatest qualities to have in life are patience and wisdom. Okay, it was rather fast. I'm sorry, folks. Thank you very much. Yeah.
So I am an acolyte of your ideas about interdisciplinarity. I'm the president of the Interdisciplinary Research Honor Society here at Virginia.
Oh, great.
The first of its kind in
Wonderful.
education.
Wonderful.
But I have a couple, a two-pronged strategy question for you. So one, an article just came out that looked at NIH grant funding, and one of the groups that gets the least funding are interdisciplinary proposals. As a young researcher trying to pursue interdisciplinary research, would you suggest that I seek to sort of apply in a siloed manner and then just do interdisciplinary research, or try to pursue interdisciplinary applications?
Yeah.
And likewise, the second part of that is, I have a dream of a telehealth program here at Virginia Tech. I think it would be amazing, but maybe that's not the way to move forward. Maybe we don't need to create siloed interdisciplinary programs, but maybe we need to come up with a way to make our programs more interdisciplinary
Okay.
entirely.
All right, it's a lot there. So let's do the first one. The need to have a greater sensitivity and utilization, appreciation of interdisciplinary research within the NIH environment. I think that's basically what you're saying, right? I think the answer to the question depends upon what the project of the question is. If it's what will play well today that wouldn't have a few years ago, is if the nature of the collaborative effort requires implementing something, doing something, because the big buzz now in NIH is implementation science. And it seems that interdisciplinary collaboration is just ripe for that. There have been several really neat articles that have been written on implementation science that might, and only you can determine if you read them, the value added, and then you make a decision if that's one strategy you want to use. If you got a piece of paper or something, this is easy to remember, swolf, SWOLF @emory.edu. I'll send you a total PowerPoint on implementation science. Oh, I'm sorry. I'm sorry, I don't know those. That's very admirable. That's kind of one strategy. And the other that you may have talked about is if you're wanting to pursue the concept of telehealth, and I presume there's a very specific application you might have in mind, and I know nothing about the state of Virginia at all, is to explore the possibility of creating a model project. So you don't do it all at one time. You start with something that, for whatever reason or reasons, will resonate with people, whatever discipline they are in this state, and you make some inquiries first. And you explain the circumstance, what you want to do, what the value benefit is to the state, what the future national benefits would be for evolving from this. It's from my way of thinking right now, to do something that huge at a federal level is a major undertaking, and probably would be something that would resonate more with a large group of experienced researchers. But why not appeal to your state? And I'm sure that in that context, if there's a right person or people, and I have no idea what I'm talking about, but hopefully you do, that one can contact first. And in the same spirit we were talking about previously, how do you make this work? Who do we need to talk to? What should a team look like? If we presented to you an abstract that highlighted the value added to Virginians and an estimate of the costs, where can we obtain support to enact this model? Just a thought. Sure.
So I had a question about your Excite trials. And so following the immense success of your Excite results and constraint-induced therapies, do you guys, I'm just curious, do you guys think about having some follow-up studies from that and maybe take those more chronic patients, maybe doing the interventions that you did in patients, stroke patients who are even more chronic, say years. And I'm thinking about it from being a clinician. You know, there are this huge portion of stroke patients who are out of the healthcare system now, years after stroke. They're probably not getting any kind of therapy. So I don't know if you had any of those kind of thoughts, or do you think the period from 3 to 9 months is a fair representation of chronic
Well,
stroke?
It's a difficult question to answer. First of all, I think at this point there are over 150 constraint therapy studies in stroke. And
The reason I'm asking is it seems to be like current, most recent research is saying that there appears to be no plateau to how late you can still show functional recovery, and that way it has
there's
evidence is there in terms of neuroplastic changes that can happen.
Well, there's no simple answer to your question because, once again, what makes the answer complex is that it would be hard to convince most agencies, federal funding agencies, that of the value added for someone many years after stroke, because the resources aren't necessarily there to do that. The interesting question is, and if I were going to do something like this now, I'd be saying, let's define what we mean by how many years after. Let's see if we can find folks, whether they had constraint therapy before or not, who meet those criteria, and can we induce measurable changes that impact the quality of their life? That's kind of one stream of consciousness. Another, the more sadistic and mean one, is, so what if you can do this? At this point, what does it add to the quality of their life, and how much is it going to cost an insurer, and who's going to pay for it? Because we believe that rehabilitation is best at a certain point in time. And as you all know, the time available to treat patients is becoming more and more constricted. And that's a tragedy of its own kind. We're considered low-hanging fruit in the healthcare system, and to some extent expendable, despite the fact that stroke is the fifth leading cause of death in this country. I don't think we've ever, with all due respect, I don't think we'd ever deny a cancer patient chemotherapy or radiation therapy after their cancer, and I don't think we'd ever define it's all got to be done within 1 month or 3 months. It's all in how we're perceived, and I think it's a very complicated story. I just have concerns at this point as the bars changing continuously in a more acute direction. I can tell you this from the stroke network. It's a whole other story. That I'm involved in looking at clinical trials that people have being put together in the area of rehab and recovery. Things move more and more towards an acute stage, and that has its own set of problems. But the answer, the reason for doing that is somewhat obvious. It's the potential of those individuals to have more favorable plastic changes and have longer life continuum in which they can exercise those changes is what drives those kinds of decisions. I think pains me to say, I think it would be very difficult at this point in time to convince someone that
I agree with your point, but I thought maybe the onus lies on us as researchers to kind of correct the most updated thoughts on driving the healthcare system all the time. In other words, trying to influence how healthcare is provided.
I understand.
So guys, I had to stop this, but we need to feed him again in his last room. So thank you very much for coming, Steve. Thanks.
Oh, you're my pleasure.